It's not
Yes.
just something that you just do it as a formality. You must know what was done, why it was done. You must think about write about the complications so that you know, okay, these things happened in this patient, how you could have avoided it. There was a mortality, why did it occur? Tomorrow, go out of this institution and start practicing on your own, you will need it. How many of MEOT students are attending the exam, appearing for the exam this time? Okay, we got 17 people. Let us start.
Okay, sir. Good morning. Good morning, everyone. Presenting a case of a 34-year-old lady hailing from Siliguri, West Bengal. She is a homemaker. Presented with chief complaints of fever since 1 month. History of presenting illness. She was apparently all right a month back. She then developed fever, which is moderate grade, sudden onset, intermittent type. It is associated with chills and rigor. It is followed by sweats, profuse sweating, and relieved on medication. Also complains of chest pain, sudden and onset, which is sharp and localized to the right lateral chest wall, and it is more on deep breathing, non-radiating, and it is relieved on pain medication. Uh, no history of cough, no history of breathlessness, no history of hemoptysis. There's no history of wheeze, no history of weight loss, no history of any chest trauma. Treatment history, she actually presented with 7 months of amenorrhea with history of reduced fetal movements, and in the outside hospital she underwent medical termination of pregnancy on 19th of August for the same, And empirically, she was started on antitubercular drugs. And for the right-sided collection, she had pigtail inserted as well. She gives no other history of any comorbidities. Family history, there's no history of any TB contact. Personal history, her diet is mixed. Sleep and appetite both are reduced. Bowel and bladder normal and regular. Gives no has got no habits. General physical examination, she's well oriented to time, place, and person. She's moderately nourished and built. Height of 154 centimeters, weight of 48 kgs, with a BMI of 19.9, which is lower limit, uh, just the lower limit of the normal range. Heart rate is 88 beats per minute, regular. Blood pressure 110 by 68 millimeters of mercury, measured in the right arm in supine position. Respiratory rate is 16 cycles, regular, thoraco-abdominal type. Temperature, she's febrile. There's mild grade of pallor present, noted in the subconjunctival mucosal fold. Uh, Otherwise, the tongue and the palmar region were all normal. There's no cyanosis, there's no clubbing, no icterus, lymphadenopathy, no edema noted. Coming to systemic examination, respiratory system, upper respiratory tract was normal. There was no sinus tenderness noted. No flaring of the nasal alveoli. The oral cavity, good hygiene. Lower respiratory tract, on inspection, the shape of the chest appears normal. Trachea appears to be normal. There was drooping noted on the right shoulder. Left supraclavicular fullness noted. There's decreased movements on the right inframammary, right infrascapular region. No apical impulse could be seen. On palpation, there's mild tenderness noted over the right mid-axillary line, fifth intercostal space, over the site of pigtail insertion. When examined, the pigtail was already removed. Apical beat was felt in the left intercostal space, 1 centimeter medial to the mid-clavicular line, and it was normal in character. Um, Chest expansion, the total chest circumference in normal breathing 78 centimeters. The right hemithorax 38 centimeters. On expansion, it was 40 centimeters. Left hemithorax was 40 centimeters normal. On expansion, that is on deep breathing, there's 42 centimeters. Focal fremetus was decreased on right inframammary region, axillary, infraaxillary, infrascapular, and interscapular region. However, vocal fremetus was normal in the left hemithorax. On percussion, there was dullness to the note on right inframammary, axillary, infraaxillary, infrascapular, and interscapular region. It was resonant on the left hemithorax all over the fields. On auscultation, there were normal bronchial vascular sounds heard over the left lung fields and the right supraclavicular and infraclavicular. However, breath sounds were absent in the inframammary, infraaxillary, infrascapular, and interscapular region. Other systemic examination, cardiovascular system, normal S1, S2 heard. Per abdomen was soft, no tenderness. Suprapubic region, it was firm with normal involuting uterus, non-tender, no organomegaly, no normal bowel sounds were heard. Central nervous system, her higher mental functions were normal. There were no sensory or motor deficits noted. Uh, on clinical examination and history, 38-year-old with a fever of 1 month and this history of lateralized chest wall. I mean, history of chest pain, which is lateralized and sudden onset. It is most likely an infective origin, and with clinical findings of reduced tactile fremetus and vocal resonance on the right infrascapular and right inframammary infrascapular region, more likely to be right pleural effusion, uh, secondary to a paranymonic, I mean, most likely a paranymonic effusion with no complications.
All the last paragraph that you went on saying, reiterating the whole history was not necessary. Okay.
Okay.
So you're just wasting the time saying all that all over again. And so, okay, now what is the differential diagnosis? What before that? Let us go into the history. Do you think the
Okay.
MTP was due to this pneumonia and empyema?
Yes, so with a history of 1 month of fever and then presenting with chest pain, likely to be pneumonia, and first she presented pneumonia and then this effusion.
But what the pneumonia? Was she hospitalized at that time? Did she require any support,
Uh,
respiratory
from
support?
from
Uh,
what she gave me
that
the history,
it's
it was
unusual to have just a new fever and then patient losing the baby.
yes.
That's not normal.
Yes, the treatment history, as she told me, upon 1 week of fever, which did not subside, she consulted in the outside, I mean, elsewhere in the West Bengal itself, where they treated her on antibiotic. And then all this MTP happened. Upon that, also the fever did not subside. And then she went to some higher center there. Further investigations were done where tuberculosis was ruled out with the sputum examination, and pleural fluid was also analyzed. But empirically, she was started on ATT, but she herself discontinued it after 2 to 3 days. She told me she had taken, and then with pigtail inserted in situ, and here she was referred to the pulmonologist, and then a referral to us. The history was like
All
this.
this history you didn't tell me. What was it? Was it a serious effusion? Was it a serious effusion? Was that purulent or blood stain? What was what when they put in a pigtail? What came out of it? That
It
you
was
should
a serious. It was. I mean, when we received here, when I saw here, only 100 ml serous fluid was outside,
serious.
and that was serous.
So
Yes.
okay, all right, serious. So it is. What is the differential diagnosis in this patient? Why is it not as just a consolidation? According to your
One is one
clinical
is
findings.
clinical findings. It is more in favor of effusion. If it is in consolidation, then the tactile fragmentus and tactile fragmentus is increased in case of
Okay,
consolidation, which is not here in this case.
and then
And the vocal resonance as well is diminished, which is increased in case of consolidation.
what more?
And
What do you get in
there is
consolidation?
no the breath sounds as well. There are no added sounds or any bronchial breathing pattern is not noted here. It's actually diminished breath sounds.
You should say that in three words. Tactile
Okay.
femoritis is not diminished, I mean not increased. There is no increased vocal fremitus, and then there is no bronchial breathing. That is why it is not consolidation. Tuck instead of telling me a whole story. Okay, you must learn to talk less and then convey more. Right? Okay. Then why is it not a mass lesion?
The history for draining it out and
Yeah. You
uh,
have a history of tapping and then a pigtail insertion with fluid being drained. That is one
is
positive thing. Second thing is that it is more likely, if it was a de novo patient without any intervention, then you would look for, because there also you will get dullness, there also you'll get absent breath sounds in a mass lesion. But generally, mass lesions, unless it is extensive, very big, the CP angles are usually free in the mass lesion. Whereas in an effusion, it starts blunting the CP angle and then progresses up. So it is most likely clinically you think that this is a effusion.
if you
All right. Now what do you want to do?
further investigate her chest X-ray. This was before the pigtail insertion done outside. It's a well exposed, well centralized chest X-ray PA view. with the normal cardiac salute. On the right side, there is blunting of CP angle with a homogeneous opacity covering the mid and lower lung zone. Uh, it is most likely, uh, however, the lenticular opacity is not noted, but the angulation is more obtuse, so most likely a pleural effusion on the moderate right pleural effusion on the right side is noted.
Okay.
And there is no crowding of ribs. Uh, as such, no signs of volume loss any noted. So only positive finding is moderate pleural effusion on the right side
Mm.
uh, without any mediastinal shift.
Mm. For this, they put a pigtail.
Yes, sir. This is the chest X-ray where pigtail was inserted.
Pigtail is way down below. Most probably it is blocked so that it has not drained the all the things. What else could be the reason?
It could be a loculated effusion, and the pocket in which it is drain is put is not in the position.
They might have created loculation so that the rest of the things is not draining. Fine. Okay. So what do you want to do now?
Upon receiving here, 100 ml of serous fluid was sent again for the analysis. There was the pH was almost normal side, is 7.4, and the cell counts were uh, predominantly lymphocytic and less than 5,000, and glucose was more than 40 milligram, and LDH was more than 1,000. So, and then. Her other investigations, the CBC total count the total hemogram showed HB of 7 with a more microcytic anemia picture, and that was corrected and with 1 PC, and the next day it was 9. Uh, Other investigations were within normal limits. Uh, Coming to CCT, this was also CCT chest was also done outside. This is a contrast enhanced CT with mediastinal view. And you can see the contrast enhancement of the pleura with split pleural sign seen noted. In the above picture, it is the visceral pleura that is noted, and the lower one is the that is marked as the parietal pleural thickening noted, with underlying collapse of the middle, and lower lobe. There is moderate effusion noted as well with loculation.
Yeah. So there
Contrast
is a lot
enhancement and split pleural sign signifying it is in uh, empyema.
and and chronicity. Okay.
Yes. And the next one is with the lung window. The left side lung appears to be normal, and with atelectasis seen on the middle and the lower lobe on the right side.
Mhm. Okay. So what are you going to do?
Mm. Full diagnosis, it would be right side empyema in stage 3 with infective pathology that is secondary to para pneumonic effusion with no complications. Uh,
What is
since
stage 3?
organizing phase,
I don't think this is organizing. Why should it be organizing? Because there is no crowding of ribs, there is no loss of volume of the chest cavity. Why do you say it is stage 3? And the history is only 1 month.
more than 10, 2 to 5 days, stage 1, and 5 to 10 days. However, stage 2 and stage 3 cannot be differentiated. It is almost always overlapping. Could be early empyema stage 3.
No. Stage 3 is what? Organizing
Yeah.
empyema with fibrothorax. So there is loss
Yes.
of volume. There is crowding of ribs. along with that. That is not seen in this patient. This is more like a fibrinopurulent stage. Okay.
Okay, sir.
So don't get confused. Don't get carried away. Just because she was operated doesn't mean that it is always stage 3. Okay. In this patient, the operation was done only because there was loculation. The pigtail was not effective, and there was a considerable amount of collection within the chest cavity.
Yes.
So this is still a fibrinopurulent stage probably, and requiring surgical intervention because it was medical management has failed.
Yes.
All right, that is your argument for the examiner.
Yes.
Don't go on to stage 3. Stage 3 looks different. Stage 3 is that there is gross loss of volume. There will be crowding of ribs. Sometimes, if it is long standing, they could also have calcification of the pleura. All these things are stage 3.
Yes.
So it is not the organizing phase. This is still a fibrinopurulent stage, probably late fibrinopurulent stage. Okay. So what do you want to do now?
She requires surgical treatment, sir, with initially to prep her up for the surgery. Pulmonary function test to look for the fitness. Her pulmonary function test was done outside with predictive preoperative FEV1 was in 71%. So she's fit enough for the surgery.
Is
And
is predictive preoperative FE1 important in this patient? You must tell us the relevant things. Predictive preoperative FEV1, PPO, and
yes,
and and it's not predictive preoperative, it is predictive postoperative. FEV1, PPO,
yes.
FEV1 is always postoperative. So that is the prediction that you're going to do. Is it relevant here? When is it relevant to have a PPO?
In case of a lobectomy or
In case of lung resection. If you're going to remove a portion of the lung, then PPO is important. Here,
yes,
this is just a mechanical compression of the lung. You are just going to be releasing the lung and then allowing the lung to expand. So the basic principle of empyema surgery is to evacuate the pus in the cavity, and then release the trapped lung all round on both on the visceral and the parietal surface as well as the diaphragm to allow proper expansion
lungs.
of the lung, and then follow up with appropriate antibiotics. So that is the principle. So now in this patient, you are not planning to do any resection of the lung, right?
Yes,
Yeah. So basically, you have to release the lung, evacuate the chest cavity of all the pus, release the lung, and then achieve good expansion of the lung.
yes,
So that is the basic principle of treatment of an empyema. And so, what will you do in this patient? What is your approach? What are the various approaches for empyema treatment approach?
Open decortication, debridement with decortication, VADS approach. But
No, that is why I'm saying you must have a very clear-cut idea. The first thing is to put in a wide bore tube, not like what the physicians do, small pigtails. Pigtails are only meant for, this thing, pigtails are not going to be effective because they'll get blocked, especially if you have an empyema,
yes,
right? So pigtail is not a good option for that. You have put a wide bore tube, drain out the entire fluid, and then make the whole chest cavity into a single local cavity, and then allow the lung to expand. This can happen in the early stages, even in fibrinopurulent stage. If you do that, since they did not do this, then there was multiple loculations, so that needs evacuation with a surgical procedure. And there you can either use a VATS approach or an open approach. Open approach is generally meant for stage 3 extensive empyema with maybe gross crowding of the ribs, and then maybe even plus minus calcification. Because if there is severe crowding of the rib, you will not be able to do a minimal invasive procedure. You cannot put your scopes in, you cannot do even a unilateral this thing. You will have to excise one or two ribs, and you might as well do a mini thoracotomy and then remove it. In this patient, you can do a VATS procedure because there is adequate space in the intercostal space. There is not so much of thickening of the pleura, and you can easily evacuate all the loculations. Why you can't do robotic? You can do robotics as well, no? Yes or no?
Yes.
Yeah, but why robotic was not done for this patient? It is an overkill. Okay, so unnecessarily extra expense. You're not going to achieve anything more. Robotics is useful when you have to do some delicate dissection in the hilum or for lung resections. Robotic is good. When you can just, all you need to do is just evacuate the pus and then release the lung. VATS is good enough, and it is less expensive for the patient. You understand?
Yes, sir.
So between the two, between open procedure and VATS, in this situation, VATS would be probably a better option because it is less invasive, and then you can achieve the same result as in open procedure because there is not much of loss of volume, crowding of ribs, and blah blah blah. So VATS is a better option in this patient. Okay. Then comes the question whether you are going to do uh, multiportal VATS or uniportal VATS, biportal VATS, whatever. So that depends on the expertise and the experience of the operating surgeon. Okay.
Yes.
So that is how you are going to talk about this thing. And then ultimately, once you have done this, you are going, the things that you have to do follow up with this is you have to achieve complete expansion of the lung, filling up the entire chest cavity, and then you will have to send the specimen for biopsy and culture, see what you grow out of it, or what there could be some other pathology that is causing the pleural thickening. So depending on that, you have to treat appropriately. Okay.
Yes.
So now what are the problems that you will encounter in the surgery in this patient?
Intraoperatively, sir, or
Yeah, in pre-op, intra-op, post-op. You have to send this patient home cured. You may get in, it is not all smooth sailing.
yes.
What are all the things that can give you trouble?
Intraoperatively, if there are multiple loculations and it will require debridement, and that could lead to a hemorrhage, more bleeding tendency. And if the pleura is thickened, the visceral pleural and the parietal pleural is very thickened, then visceral pleural on removing, uh, if is very adherent, then can even lead to lung parenchymal injury and causing air leak.
No,
And
if all
if there
these
is
happen, you shouldn't be operating at all. That is the technique of surgery. You have to make sure that you don't cause too much of bleeding on the chest wall and you don't cause visceral injury, parenchymal injury. So that means that your technique, surgical technique, has to be good. All right. Yes, it is a possibility. And because of the air leak, what will happen? Or bleeding. Bleeding causes recurrent effusion, and
Yeah.
then that further can give rise to the same get infected later on if you don't recognize it and send the patient home, and she'll come back with the same thing. So square one. So you have not done anything by your surgical procedure. If there is parenchymal injury, what will happen?
The there is persistent air leak, and the there is no adequate lung expansion, and um,
Yeah.
if there is prolonged air leak, then you have to even suspect uh, on a long term basis, it could be even a bronchopleural fistula. If it is in an earlier period, it could be just a alveolar leak causing the persistent air leak.
Now you got into trouble. So what is the definition of bronchopleural fistula? Would you expect a bronchopleural fistula in this patient? What
It,
is the definition between alveolar pleural and bronchopleural fistula? And
the fistula,
why do you need to differentiate the two?
bronchopleural fistula is anywhere that occurs from main bronchus to up to the subsegmental bronchus, and alveolar pleural fistula is anywhere distal to the subsegmental bronchus. Alveolar pleural fistula usually in the immediate post-operative period is most commonly occurs in the early post-operative period, and it can be managed conservatively. But however, bronchopleural fistula, the management strategy depends on the presentation and the size and
Good. The presentation and the size of the fistula. Okay. So now that means the bronchopleural fistula would always require probably a surgical management depending on the size of the fistula. Now, do you think that this will lead to a bronchopleural fistula?
no, sir.
Unless there is a parenchymal lesion. It can happen pre-op also. Yes, you can have an empyema because of a bronchopleural fistula and then empyema. But just a plain decortication is very unlikely to lead you onto a BPF. It's most likely 95% of the time it is only an alveolar pleural fistula. And because of the alveolar pleural fistula, you will have prolonged air leak and residual space problem. Okay. So
Yes.
when there is space that there is chances of fluid collection there again, and that again can convert into an empyema, secondary empyema. All right.
Yes.
So what will you do? Supposing there is a space problem in this patient, and the lung is not expanded fully. So what are your options?
Uh, to keep the drain for long time with the negative suction connected.
No, there are few things. You have to look for it intra-op and post-op. Intra-op, you must always, after you think that you have done your complete decortication, you have to give positive pressure ventilation and make sure that the lung expands completely.
Yes.
Under positive pressure ventilation, ask the anesthetist to blow and then make sure that the lung is completely expanding and filling up the chest cavity. So with positive pressure ventilation, if it fills up, then there are chances that this lung will completely fill up in the post-operative period, especially in a young patient. But if
Yes.
in an older patient, if there is any doubt that the lung is not expanding, then there are options that you can do on the table to help decrease the chest cavity, space of chest cavity. And what are those options? One, you can just
Phoenix nerve. Okay.
excise a rib excise a rib if it is a stage 3 and grossly crowded chest cavity, because the excision of the rib may be necessary even to get into the chest. Second, you can just shingle the ribs at the anterior and posterior ends. You just cut it at the vertebral end on the one rib, and the sternal end on the other rib above or below, so that the whole chest cavity sort of compresses. All right.
Yes.
And then what are the other things that you can do?
Phrenic nerve crushing can be done.
Yeah,
That would
no,
be
no, no,
the
no, no.
dome of the diaphragm.
Don't crush the phrenic nerve. That is the wrong thing to say. You can block the phrenic nerve, because all you need to do is, for the first initial period, the lung diaphragm to come up, so that the lung gets adherent all round, and then it can be. If you crush the phrenic nerve, then it is a permanent injury. Never do that for a decortication. People used to do that earlier. People used to do that mainly for post pneumonectomy patients, so that the chest cavity goes down. So there you can crush the phrenic nerve. But phrenic nerve crush is not a good option. At the most, even on the left side, definitely not, because it will paralyze the diaphragm completely. On the right side, it most of the time it is protected. Even the phrenic nerve is protected by, because there's a liver there. So phrenic nerve, that even if the diaphragm comes up, the rest of the bowel from the abdomen cannot herniate into the chest cavity. So phrenic nerve, generally people used to do this phrenic nerve crush for post pneumonectomy empyemas or post pneumonectomy patients. But the idea is, nowadays you got long acting local anesthetics, BPVK and this thing and all that, so that you just inject that, leave it there, and then sometimes people have used the paravertebral catheter itself can be used to give continuous infusion there, and allow the lung and diaphragm to come up in the post-operative period in initial 24 to 48 hours. So that can be done. You can just disconnect the rib, anterior or posterior, not the same rib, cavity closes down. And then good physiotherapy, especially in a young patient, a good chest physiotherapy is absolutely important to get the lung expanded as quickly as possible within 48 hours. If you don't get the lung expanded within 48 hours, then you miss the boat. Then you will end up with a persistent space problem. And then the only other option that is left to you is to follow up with a thoracoplasty or a Elosher window, depending on the site and depending on the chronicity and depending on the amount of infection that is persistent.
Yes.
Okay, these are the problems that you can get on even in a simple, straightforward empyema. The examiner will ask you these questions. What will you do? So first thing is that in your principle of surgery, you have to evacuate the pus, release the trapped lung, ensure that the entire lung is expanded completely to fill up the chest wall and cavity, and then treat with appropriate antibiotic as per the culture and sensitivity. These are the four things that you have to mention in any empyema case. All right. So if you you will definitely get an empyema as a thoracic patient. If you get an empyema case, you have to differentiate differentiate empyema from a consolidation or a mass lesion, because the breath sounds are all decreased in all these three. So then you cannot say empyema, you will have to say effusion, because you don't know. On a clinical side, clinical this thing, it could be fluid, it could be pus, it could be hemothorax, it could be blood. You can't unless you put in a needle, you can't differentiate the three. Then once you have diagnose that there is fluid in the chest, then you have to go through the lights criteria. You have to see whether it's a transudate or an exudate. Understand? So then, depending on that, your treatment varies. If it is a transudate and it is due to one of the failures, cardiac failure, renal failure, hepatic failure, then you have to treat that medically accordingly. So that itself may suffice. Otherwise, if it's just a transudate, you can even put in a tube and clear up the entire this thing. Make sure that the lung expands, and then once the space gets obliterated, there will be no further collection. If there is empyema in the early stage, you can still manage with the tube or VATS evacuation if there is localization. If there is stage 2 or stage 3, you can still, in expert hands, VATS can be still be done, or ultimately you have to do an open procedure. If you have a problem post-op with persistent air leak or space problem, you may have to resort to further things. As we mentioned, persistent space problem with collection and persistent sepsis, you may have to resort to either a thoracoplasty or a Elosher window. And remember, this should not be offered to a patient in the primary setting. Both Elosher window and thoracoplasty are mutilating surgeries, and they can cause severe chest deformities and then quite considerable amount of morbidity to the patient. So you always do all the conservative measures and then good physiotherapy, especially in younger patients. Make them do vigorous chest physiotherapy for at least 2 to 3 months. And in spite of that, there is not much of improvement, then only offer this secondary procedure. Okay.
Yes.
This should be the treatment for empyema at all stages. I mean, first stage, second stage, and third stage. Because if you get a case, if there is an empyema, that you'll definitely get a case for the exam. All right.
Yes.
Any questions from anybody?
The posterolateral thoracotomy, could we discuss on open decortication?
Yeah, you can go ahead. Tell me how we'll do a posterolateral thoracotomy.
From positioning, sir.
Naturally, you have to position the patient before you cut open. Proper positioning will be proper exposure. Proper exposure leads to half the operation that can be done well and comfortably. Okay, positioning is important for exposure. Good exposure is the half surgery done. Tell us.
Yes, lateral decubitus position with the operating side up, and then it should be about 90 degrees in the lateral decubitus position, and uh, extension of the shoulder joint up to 100 degree, and elbow joint flexion up to 90 degrees over the head, so that the exposure is good, and and this arm is again rested to prevent any ulnar injury or medial nerve injury at the wrist. It is rested with the armrest and wrapped with the Gamzee roll. And the contralateral axilla is again protected from the brachial plexus injury or the pressure point with the uh, gel foam or bean bag. And the neck and head is also supported well. And at the hip At the hip level, again, there is pressure points are covered, uh, and the lower limb is uh, flexed, both slightly flexed at the hip and the knee joint, with a pillow separating the upper limb. That is the one which is facing the ceiling. Uh, then it is well wrapped so that the patient doesn't move around, and it is broke. And then after the uh, position is satisfactory, you can connect the cautery pad and the DVT prophylaxis. Either mechanical pumps can be connected or the stockings. Uh, then the table is broken at the middle so that the ribs ribs are opened up and the intercostal space is wide enough once you enter. Once the positioning is done, then you
Hold
mark
on,
the.
hold on. There are two important things in positioning for a posterolateral thoracotomies. One, if you are doing an open procedure, the patient is positioned in such a way that the back is almost to the edge of the table, on
Yes.
towards your side. Okay,
Yes.
so that it is easier for the surgeon to operate from there, from that side, from behind. Second, you have to pull the shoulder, the upper shoulder up in front, so that the space between the spine and the medial border of the scapula is widened, so that you can go through that space. If you don't do that, there will be very less space between the two, the spine and the scapula, and then you will end up with having problems. You are trying to access that space. These are two important things that you have to do. As against VATS procedure, in VATS you do the similar procedure, but you will place the patient more towards the anterior aspect, because most of the time most people do
Anterior.
VATS procedure from the anterior approach. Although posterior approach is also being described, nobody does that nowadays. It is always anterior. So the patient is positioned much more so that the anterior chest wall is closer to the edge of the table, as against the open procedure. This is important, because if you don't do this, you will struggle through the entire operation. All right. and
Yes.
and the space between the scapula and the spine has to be widened, so that you have adequate space. All right. Painted, draped, everything. Now what is this marking of your incision?
Incision posteriorly, it has to be, the upper extent has to be in between the spine of the scapula and the lateral border of the spinous process of the vertebrae. Uh, and the lower in the another
Spine of the
marking would
scapula.
be
Spine of the scapula. You want to go that high? Spine of the scapula is at what level?
T2 levels, T2, T3 level.
Why do you need to go up to the T2 level, unless you're doing a thoracoplasty? You don't
Okay.
need to go up to that level. See, the first marking is the tip of the scapula, one or one
Centimeter.
to 2 centimeters below the tip of the scapula. That is the point. Next,
Yes.
anteriorly, you have to do the submammary area, submammary incision, like the submammary portion. Posteriorly, between the two, the spine, the medial border of the scapula and the spine. Okay. So you may just go. It varies from how much higher you want to go. So if you go to through the fourth or fifth space, that's more than, T4 or T5 is more than enough for a posterolateral thoracotomy. Unless you want to go excise this second or third rib, then for thoracoplasty, then you have to go up between the scapula and the spine, right up to the spine of the scapula. Okay, that is up to T4, T2. So, all right, then you have made an incision.
Skin incision, then subcutaneous level. Uh, You then posteriorly you'll get the latissimus dorsi. In the muscle sparing, both latissimus dorsi and serratus anterior are spared. In other method where only serratus anterior can be spared by separating the thoracodorsal fascia and then cutting the latissimus dorsi posteriorly. Then once this is done, you retract the scapula with the scapula retractor, with the Davidson's retractor, and then from the second rib count the space up to the sixth rib, and the one space above the space above the sixth rib along the superior border, you can cut the periosteum either through cautery or can be incised, and then periosteum is then elevated with the periosteum elevator, and then if there is no crowding of the ribs, then you can easily enter, or periosteal can be stripped off anteriorly and posteriorly along the rib border with the Doyne's respirator. And then once you've made entry into the pleural cavity, then you can put a phenotype spreader to spread the to get a good exposure, which is done slowly to prevent rib fracture. Once entered, to look for any adhesions. Uh,
In an empyema, you have two options to. In an
Yes.
empyema, once you come to this stage, once you open the intercostal space, you can put in a small spreader, just retract a little bit by bit, and then you can strip off the parietal pleura from the chest wall, and then gradually expand the ribs so that you go into the chest cavity. Then
Yes.
you incise the parietal pleura, open the empyema cavity, evacuate the pus, and then you expose the thickened visceral pleura and then go into it. The other way of doing is to go into the empyema cavity directly and then excise the parietal pleura when you are coming out after you've completed the decortication. Both ways it can be done. So most of the time, what we do, if there's a early fibrinopurulent stage, the parietal pleura can get stripped off very easily. So you strip off the entire lateral aspect of the parietal pleura, then incise the parietal pleura, excise most of the parietal pleura from the chest wall, then evacuate the empyema, expose the visceral pleura that is trapped, make a cruciate incision on the visceral pleura which is visible, and then gradually develop a plane between the thickened visceral pleura and the underlying parenchyma. You can use blunt and sharp dissection depending on how well the pleura is stripping out, and also you can use intermittent ventilation of the lung so that you have traction and counter traction of the surface so that you can separate the visceral pleura from the parenchyma. This this is how, and you work your way all around the lung, right up to the apex, down to the diaphragm, down to the costophrenic recess, and then also make sure that the parietal pleura over the diaphragm is also excised so that the respiratory mechanics is restored. Unless you do this, your post-operative ventilation is going to be problematic, and the patient's breathing efforts will not be adequate, and that will lead to incomplete expansion of the lung and persistent space problem. So these are important steps that you have to do during your surgical procedure. And at the end, you make sure that there is not much of air leak. If there are any small major air leaks, you have to take care of that. There are various methods to take care of the air leak. Either you do a simple suture and close the air leaks, or you can put a patch, or the sealant patches that are available, or some people have also used a blood patch and things like that, the coagulated blood, this thing onto that area. So there are different methods available for the surgical. So you should know all these things. You should read about it, different ways of treating prolonged air leaks. Okay, on the
Yes.
table. How do you treat different air leaks, different methods, and then make sure that the lung expands completely on the table. Put proper tubes, both anterior and posterior tubes, so that the lung expands completely in the posterior. Remember, on the positive pressure ventilation is on the table, but once you have extubated, the patient has to breathe on his own. He will have severe pain. So you have to make sure that the patient is going to be given proper analgesia, proper physiotherapy, and then the breathing the mechanics are restored, and the lung expands. And make sure that the post-operative management physiotherapy is diligent, so that the lung expands within 48 hours. If you don't do that, beyond 48 hours, that lung will never come up. Again, you will end up with a residual space, and your entire operation would be a waste. So that is why the reason we insist on you people to look after the patients in the first 24 to 48 hours, make sure that the lung expands, make sure that the lung gets adherent to the chest wall, and that also reduces the air leak and obliterates the space. So it is much more difficult to look after a post-operative thoracic patient as compared to a cardiac patient. Cardiac patient, you will just hike up the inotropes and then hope for the best, because the patient is not going to do anything. Here, the patient's effort is a lot more. He has to breathe, he has to cough, he has to clear the secretions, he has to expand the lung. So that requires diligent post-operative management in the ICU.
Okay.
So the homework for you people now today is to go back and read what are all the methods to treat prolonged air leak, and what are all the methods to treat persistent space problem.
Okay.
These are the two major complications of any thoracic surgical procedure. So you must know how to deal with this. Okay?
Yes.
Yeah. At least you must know the different techniques that are, if you don't know the entire this thing, you should know what are the things that are available and how to do them. This will definitely be asked in your exams. Any other questions? Okay. If there are no more questions, we'll close the class. Thank you, Amulya.
Thank you, sir.